It says this is the second installation of this, and we are recording these. So anyone who missed last time, please feel free to have a look at the intro session from a few weeks ago. And I'm just going to pick it up and run through, and I'm suggesting that we actually just take our time and run through the program. And last time I just talked at you for a long time, which is has its virtues but also has its downsides, and doesn't engage you all that well. So I thought for this I would probably look at making it hopefully more interactive, and pausing after each section and maybe taking some discussion. People aren't obliged, of course, to say anything, but it's valuable. If you have questions and feel it might be a very basic question, likely is that you're not the only one who has that question. So you're doing your colleagues a favor by asking it. So this is just by way of linkage to the previous session, that the idea of the Optimal Health Program, remember, is really to build resilience in the individual and what we refer to as self-efficacy. And that's a term from Albert Bandura, and is around how people can feel that they can control their own destiny, or at least have an important central role in controlling their own destiny, because many of our patients and indeed family members feel rather disempowered by disempowering systems. And in some health services, you could also feel pretty disempowered as a staff member. So the idea of this is, if we embrace this general approach, that we will work with the patient. By the way, I use the term patient because that's sort of medical parlance. For those of you who use other terms, that's absolutely fine, if you can forgive me for the use of my term. It is actually the preferred term by most patients, interestingly enough, and there's numerous studies to show that, but it doesn't really matter. You've got to, the idea is to learn, and that's a mutual learning, actually. You learn about the individual, and they learn from you about strategies to help them. But the importance of context cannot be underestimated. So context says that this is an individual moving in their own social, family, and other networks, and in a broader society. So acknowledging all of that, and indeed in their own particular health system. So the virtue of this program is that we can be hugely adaptable in terms of the context, responding to the context of the individual, and building further strengths within their world to help them. And then we look on setting particular goals for the individual, and the summation of these come into what are called health plans. So I'm going to run, I did mention all this before in the last session, but it's really imperative that you understand how these work. I do use this analogy of driving a car, and as I said last time, when we've had cultural adaptations, it's been a little bit different. For example, in Malaysia, our lovely colleagues adapted it and used the idea of a plant, which you plant and you nurture. But for me, a car sort of works as an analogy. And the difference with OHP from most other programs like this is that the emphasis is not on unwellness, it's really on wellness and what you need to do to remain well. So, far too often we are looking at problem solving for people when they become unwell, rather than asking ourselves what are the things they can do to keep on the straight and narrow and keep well. And I always say, it's funny to me, patients come rather apologetically to see me when they're well, and they say, I'm not sure why I'm here, because things are pretty good. I say, well, that's the most important time to come. One, you've got coherence of thinking, hopefully. Secondly, you're in a space where you're not having to fend off unwellness. So you've got time to concentrate on the session, and you've got an opportunity here to reflect on the things which you're doing now, which are actually helping you to stay well. And if things become wobbly for you going down the line, you can remind yourself of these. So the health plan 1 is about that. Health plan 2 is when things are under stress. So you work in things like early warning signs, and those can be individuated to the person, and then also things you need to do. And I'll talk through the strategies which we employ in OHP. And that also allows one to bring in one's collaborative partners. So I talked about context earlier and collaborative partnerships. So collaborative partners are everybody within your world who could play some role in your mental health and well-being. And you can choose to engage people in certain ways. And you could also choose to distance yourself from certain people. You know, if you have somebody who's rather toxic in your environment, you can actually choose for that person to be dealt with in a way which it means that it's not impacting on your mental health. This is a process which is pursued by an eco-map, which again I'll share with you in due course. And health plan 3, which is burning red here, is when things go awry, and that's when you need maybe to go into hospital, or you need a whole lot of extra input. But it's not a disaster. It's a learning opportunity. So one of the tools we use is, if you land up in health plan 3, we actually track back and look at what happened on anti-dating, the need to use health plan 3, and that allows us to understand again longitudinal context, and also ask what we could have done better, what we could have done different, what maybe didn't go right with the health plan, and then use it as a learning opportunity. So again, the car, the driving on an ordinary road on nice sunny afternoon, you are still needing to be vigilant about not crashing into the car in front of you. You need to stay in your lane, you need to check your rearview mirrors, and you need to have looked after your car and put good octane fuel in. That's like medications, not put toxic fuel in the car, like not giving into using substances and so forth. And health plan 2, as I said, is when the road's wobbly, and that could be, you know, the equivalent of potholes or roadworks or bad weather or something. And there you need to be sensible. You need to slow down. You need to, you know, use all-wheel drive. Maybe you need to have your anti-skid brakes. And you could also ask people to assist you, and you might even decide under that you need to take your car in for a service. So sometimes that's required. And health plan 3, the equivalent is where you break down. As I said, it's not a disaster, but you might need to be towed in to the hospital equivalent for a car, and you then go through the process of reflecting why this has happened and how it can be best used as a learning opportunity for everybody. The ideas which I've given you really are backed up by various models and tools. So we're not just putting you in your car and sending you off without teaching you how to drive the damn thing and how to look after it. And there's various tools, including the I Can Do model, which is essentially a stress, vulnerability, strengths model. We also look at, you know, that you're going somewhere meaningful on the road of your life, visioning, goal setting, and so forth. And we are very interested in you as an individual, and it's not just about you as a person who happens to have mental health issues or physical health issues, And we actually start off the whole process by looking at you and your values and the areas of your life which are going well and the areas of your life which are going not so well. And here we cover physical, emotional, intellectual, spiritual, occupational, and social parameters, and we map these onto a health wheel, which I will show you. The I Can Do model, as I said, is stress vulnerability model, but with strengths thrown in and developing particular strategies. And then the visioning and goal setting, as I said, is about going somewhere meaningful and value-driven, if you want to use acceptance commitment type terminology. So we start off by really sort of blue skying this a bit, rather than coming in and say, tell me about your auditory hallucinations or the voices you're hearing, or tell me about your mood. It says, let's just step back from that and let's ask about why you are here and what you would like to achieve in terms of health. So immediately from the outset, the emphasis is on healthy. And you look at painting in whatever it is, your mind, your surroundings, your body, and you can think about all of these aspects, and they might bring their own things to it, and physical health, mental health issues, social health, I guess, family health. All of these things can be brought into this discussion. And the tools which we have, and as you know, it's a manualized program. I think you've all been given a copy of one of the workbooks, which you can look at, and it's really important to keep referring to those. By the way, when we started this program, we had a separate manual for the clinician and a separate manual for the patient, and then we thought that's actually not walking the talk of the optimal health program. So we just have one manual, which both the patient and the clinician can use and add to. Of course, it's quite symbolic and important that it belongs to the individual, but you can ask permission as a clinician to also contribute to it. And with the electronic version, which is getting close to beta testing, I think, will allow some of these things to be done in an electronic way as well. So coming back to the notion about health and that health plan 1, let's reflect on the things I do which actually help me, and also on the things which I do which may have a negative impact on my health. And that can be pretty obvious, and you actually look at working through that with the individual. You might start with one or two ideas, but you don't really want to put your views particularly onto the person. This is an activity which we would do if we were doing this in a group format, and the idea is for you to reflect on your own stuff. What does it mean to you to be healthy? Sharing your thoughts and writing these down. So, for Davis, it would clearly be grooming his beard, going surfing, and thinking about optimal health. That's what his strategies and activities are. Correct, Davis?
Yep, absolutely right.
You each have your own, and you each have your ability to evoke some of these things from patients. So that's one very open opportunity to engage the person in a discussion. And it doesn't mean you leave all that behind when you move on through the program, because the idea is, as you go through, the person develops these component parts of their own workbook, and can come back and forth. There is a pedagogical journey through OHP, but it's meant to be customized and changed as you move. So it's not a static thing either. Now, all of you will recognize this, and it's straight from cognitive behavioral paradigm from Tim Beck. And basically, it tracks what you're doing and how you're feeling. And I've changed it a little bit in the terminology just to make it a bit simpler. But P, you rate pleasure, which is from 1 to 10, and then E is effort. And as you know, in CBT parlance, this is around pointing out to people a number of different things. One is that actually, although they might be feeling pretty miserable and might say to you, I never feel okay, actually, if they track it day to day, they might actually well have variation in mood, and certain patterns might emerge, and certain things which might be make you feel better could be determined. Certain things which might make you feel worse can be determined. It also makes clear that there is not always a correlation between effort and pleasure in the sense that some things which actually take a lot of effort can be extremely pleasurable. So, I would say something like going to the gym, which I personally hate, but if I do it, it's a lot of effort, but I actually get a lot of pleasure from having done it. So, that's an example. Other things would maybe be watching TV at home. Well, that's not all that much effort, but it's quite a lot of pleasure. So it gives all of those things. Again, you would be aware of this. It's very standard. But what we have done is a change with this and ask people to determine what they want to actually track. And you can see at the top, you can actually add your own. And in the electronic version, you'll be able to do this on your phone. And this is just an example. This was for somebody with an eating disorder to show them the correlates between emotions and eating and when things go unhappily. So we're going to move on now. That's sort of pre-session one, and now we move into probably session one, which is about the building of well-being theory. And here we start with the optimal health discussion, which I've already started with you, and then the health wheel. So the health wheel is sort of from Buddhist influences, looks at this balance of 6 domains. The health wheel, by the way, has been validated against a whole lot of standardized measures and encompasses, as I said earlier, physical, emotional, social, spiritual or values, occupational or engagement. The reason we put engagement was some people aren't working, and then intellectual. And each of these have a definition, and it's not so much the individual ratings, but how they form or don't form a comprehensive whole. And you plot this onto the wheel. And we have a prototype of this on the electronic version. We would in this paper version, we would actually color it in. Now, what's the point of doing this? I might ask people why they think we would do this. And does it sound? Hi, Charlotte. Great to see you. What, can anybody? I mean, does this sound like a discussion which most of you would have with your patients at the beginning of your journey with them? Well, if it is, then that's great. But I must say, for me, I have to remind myself to do these sorts of things with the patient because you tend to jump in with symptoms, and you tend to say, well, how are your symptoms? And you actually don't get that sense right at the beginning about this person and the things which they actually value and the things which they think they're doing pretty well with. So that'd be one reason. So it's establishing relationship. Any other thoughts about it?
I guess it might support
Beg pardon?
goal setting and treatment planning and
Yes, absolutely, because you can look at that wheel and you can say, this is not me telling you you need to work on this or that. This is you saying this is an area which you are feeling you're not functioning optimally in. So is that maybe an opportunity to work on that in particular? And they might say, no, I'm not interested in working on that. And you say, well, you can explore that, and you could say, why? Like maybe occupational. And they say, I'm just not ready for work or something. And then you say, well, there's other ways of getting some confidence around working towards work by doing some volunteer work and so forth and so on. So you can just aggregate it in that way. Or you can just say, okay, it's your call. It's you we're interested in here. So if that's not something you want to work on here, let's choose something else or a combination of things. So and that's the sort of discussion which starts. It allows you to map things. It allows you to establish this understanding about the patient. And remember, what we value is not what patients necessarily value. And it allows you to start thinking about the stuff which is worth working for and towards. And then we move on. Any other comments about the health wheel? The health wheel, by the way, as I said, is a validated tool. We actually like to use it and revisit it a number of times through the course of OHP. I usually return to it about a third of the way through, and then 2/3 of the way through, and then at the end, and then at any follow-ups, because it allows you to compare and to track. And in the electronic version, it can just actually give you the progress. It can feed it back to the individual, because funny things can happen. That's you get a job, and you're going really well in your job, and that shoots up. But you've still got an imbalanced wheel because your spiritual pursuits and the time you used to spend meditating and doing, you don't have time for that anymore, so that's come down. And overall, you're wanting to really try and get a balance on the overall on the wheel. Okay. Making sense? Okay, so that is the wheel. Very nice tool. People like it a lot because they haven't usually had that sort of discussion with their clinician before. And this would be an example of somebody who actually has very good physical health, and they are highly spiritually engaged and happy with things, and they intellectually occupied and pursuing interests in things, but their social life isn't very good. Emotionally, they don't feel very connected with other people, and they're occupational, they're not working. Okay. So this is a very, as I said, imbalanced wheel. Now, if you think about a wheel needs to roll. That's the idea of a wheel. And this wheel would have great difficulty rolling. So it's not so much looking at the numbers, it's more about the shape and whether you have obvious areas which are going to impact on the rollability of this wheel. Okay, so we've talked a little bit about this now, and I would suggest that we don't do it now, obviously, but that you go back and think about this, and maybe buddy up with someone and go through your own health wheel or just try it with some patients. As I said, you've all got the handbook. You can easily just photocopy this particular thing and just do it to some people. You might be surprised what comes through. Okay. So, as I said, we use the health wheel both as a sort of conversation starter and a goal setter and determining areas to work on, but we also use it as a tool to measure change. The other tools we use to measure change are these, the General Self-Efficacy Scale and the Work and Social Adjustment Scale. These are really chosen from myriad rating scales because they have resonance with the ethos of OHP, and they are quick and easy and can be repeated. So we like people to do these. Okay. Session 2, you start coming to some of the more specific tools. And again, as they say, this isn't rocket surgery. This is basic stuff which you guys know, but it has nuanced and changed and morphed a bit in the context of OHP. And as I shared last time, you often think, oh, well, I do all these things intuitively. So I don't really have to do it formally. Well, actually, that's not the case. We often don't do the things which we should do in the way which we should do it with each individual. And partly that is just because you've done it a million times. So you run through it very quickly and you assume they know what's going on. Think about the first or second time when you actually used some of these sorts of techniques and strategies and what it was like for you to learn how to use them and for you to explain to the individual in front of you or next to you to do it. And I would suggest that, that rather maybe seemingly rather pedantic way of doing it actually should be the way it's done with most people because it's new to them. So this is the self-efficacy theory, stress vulnerability model, and we very strongly brought in strengths. So it's a strengths-based approach. We look at exploring vulnerabilities and identifying and clarifying strengths and vulnerabilities, and this allows you to start populating health plan 1. Okay, so the health plans, the reason I raised them at the beginning is you need to hold those in mind because you're working towards at the end of all of this to have all of those populated. So you can, whenever you go along, you can say, okay, let's push this, or let's work together to think about what elements of this you might wish to include in your health plan. So it's not saying you need to do this. You're saying this roundabout way of talking might sound a bit pedantic, but it's important because people are so used to being talked down to, and their experience of that. So with this, it's really working alongside, so the clinician and the patient working alongside and using the OHP as a set of tools. So you would be saying to the patient, not you need to do this, you'd say, is there something in the set of tools which OHP has taught us that we could use and bring in here? No? So you do, as in pretty much any psychological strategy or activity strategy or any of these, you go back and you ask how the week has been, and if you had set some specific goals for that week, how those had gone. You might review that little weekly, the map of activities and your ratings of effort and pleasure and all of that. And you might also ask, so last session we spoke about this and that, what do you reckon and how did it go? And then you hopefully make a nice, beautiful linkage across to the I Can Do model. This is self-efficacy, again, defining as people's beliefs about their capabilities to produce designated levels of performance that exercise influence over events that affect their lives. Really, it's basically, some people prefer locus of control sort of terminology. A chap with the unfortunate name of Rotter, but that's the idea, that rather than being at the mercy of the world and at the mercy of your mental health problem, you can actually influence that and control it. And as I said, this is stuff you will recognize at least elements of. So everybody has strengths and everybody has vulnerabilities. So you actually look at working through those things. And then you try to document the strategies which you might use in the contexts of certain stressors. And this is, again, led by the individual themselves. Some people jump in with a lot of vulnerabilities and very few strengths. So there you need to, observe that and bring some ideas about what might be strengths, suggestions. And often, that's stuff from what people have told you. And this then says that you can do this for yourselves. You write down what you think are some of these and brainstorm potential vulnerabilities and so forth, and then identify day-to-day strategies. Okay, and it works like this, that strengths and vulnerabilities, if you think about mental health and life in general, everything, to my mind anyway, is pretty dimensional. We all have certain strengths, certain vulnerabilities. Some people quite like to use here, initially at least, a more medical sort of model, explanation of physical disease if you prefer. Sometimes it can be helpful depending on the individual you're working with. You would then be able to say, well, everybody has this makeup, so let's understand at an individual level these strengths and vulnerabilities, the strengths being personal qualities, skills, talents, interests, aspirations, and there might well be environmental strengths. And then there are the vulnerabilities. I mean, there's genetic factors and so forth. So, here is an example of this, a man who had a very strong family history of myocardial infarction. And his grandfather and his father and his paternal uncle all died in their 40s of myocardial infarction. So that's a big vulnerability for this guy. But his strengths were that he actually knew about this and he was motivated to take action. So he had these personal qualities. And also he was actually very good at swimming. So he used that skill to strengthen himself further by going every 5 days a week to swim at the local pool. And guess what? He died of a heart attack. But he was 94. So he's understood his vulnerabilities, he's done something about it, and he's ameliorated the impact of his vulnerabilities. Throughout the workbook material, you can, there are examples just to sort of drive things. And you can see they're very generic, and they do preference things which sometimes you might forget to bring in, things like caring. I have a very lovely patient who I've known for many years who's had a lot of physical health problems and mental health problems and had to give up work and so forth. But she's a very lovely, caring person. And I keep on putting this back to her about that being an enormous strength, and she actually cares about other people. So that led then to a discussion about how, even though she is physically disabled, is in a wheelchair, she had a grandmother who she used to spend a lot of time with. So when her grandmother died, she had more time on her hands, and so she decided there was a little old lady who lived next door who was lonely, and she started volunteering to go and spend time with this lady, and it built a relationship, and then built actually to an extent where she got a job as an NDIS support person, right? And feels amazingly better about herself. Her physical health problems are worse because of the nature of her physical health problems, but she's built the strengths she has, which were friendliness, humor, and caring, really caring about other people. These are the sorts of vulnerabilities which can be. There's chemical imbalance and chemical changes in the brain. That's a whole discussion in itself. We try and sort of put that into a sort of understanding context around it. And it's not to be saying, you're feeling miserable because you've got a chemical imbalance. That's not the sort of way we'd be looking at it. But we might talk about brain chemicals because that's an entree to a discussion about medications, which is part of what we do. And as I said, then you are able to start populating Health Plan 1. And you could see how that would be, to develop an everyday maintenance plan for well-being, strengths, vulnerabilities, from a why to a different frame, solution-focused frame. Any comments about any of that? Does it sort of make sense? Does it resonate with what you do anyway? Is it completely different from what you do? Is it sounding so obvious why you're even listening to this? Who would like to? Emma, I always pick on Emma.
I knew you would as well.
Yeah.
It resonates with me anyway in a similar way that I would work with my clients. I think as a social worker, my background's social work, and we do look at the various strengths, strengths-based approach, and we look at systems and environment of a client, not just what's internally happening for them. So it definitely resonates with me.
Yeah, and that's I know you're a social worker, and we have worked together.
Just making
in a
sure
number
you
of different
remember, David.
contexts. And that's exactly right. That understanding that context and speaking that language engages people in a way which, if you take a very medical approach, it's not going to happen. But it could lead on to that. So that's another point I'd like to make with this. I think Clarity Healthcare and all of the other partnerships we have enormous strength in the fact that we're multidisciplinary, because we do bring different perspectives which are meaningful and useful and can deploy those. OHP doesn't cut across any of that professional skill set. It actually embraces those. And also, if you come across individuals who have a particular requirement for a particular intervention which you feel as the clinician involved can't deliver, then you have the great luxury within Clarity to be able to find somebody who could do that for you. And it doesn't mean that you stop working with the individual, but you can come to a joint decision to bring in another person with that skill set. Okay. Thank you, Emma. Would you like to nominate somebody else then to say something?
Could be dangerous. I nominate Matthew Warden to speak next.
But I knew you were going to do that. This is just like going back to St. Vincent's.
We've all worked together for too long, maybe.
I think it sort of formalizes a thing that we sometimes forget to do, which is asking why the patient, or what the patient wants to do, why they're there seeing you, because from a medical point of view, you get a referral from a GP and it says, please see this patient about something or other, normally one line. And that may not actually be what the patient wants to talk about or what they're concerned about. And actually having a formalized sort of process like this, where you try and gather all the information in and then think about what they want to do about it, is a very helpful way of making sure that you're actually not just repeating the things that have frustrated the patient for the last 20 years when they've seen other clinicians and not got what they wanted answered.
Yeah, look, thanks, Matt. That's a very important aspect of this. It enables a discussion, because as Matt is pointing out, you know, people, it's surprising how many people will come and say, oh, I've seen, you know, 10 psychologists and they all said the same thing and it was all useless. And you say to them, well, did you actually feed that back to the psychologist? And they look at you, you know, like, well, I couldn't do that. But, you know, I said, they can't read your mind. I can't read your mind. You got to tell me, you know, what's working for you or isn't, and what you want to work on and what you don't want to work. But people are intimidated, especially by doctors, the point of it, we need to show that we're open to that discussion, and that's again reinforcing this notion about it's not you doing this, it's you and the patient looking at this as a tool set. Okay. Good. Thank you guys for that. And I'll go back to sharing screen. I'm going to do one more session and then I think we'll take a break till next time. The session 3 builds on the I Can Do model, strategies, stressors. The reason we spend quite a lot of time with this is it's a simple tool which people feel is very, very helpful in their everyday. And the self-efficacy component of this is that, you know, yes, we all have strengths and vulnerabilities, but there's lots of stuff we can do. Okay, and then you start working onto Health Plan 2. Again, you go back and you revise. You look at this, maybe what you've mapped during the week. You might have given some particular examples of how to deal with certain circumstances. And you also start talking about stress. And stress, of course, is ubiquitous in everybody's life. Nobody has no stress. And indeed, we need stress if we're going to have a meaningful life, because we're going to have to develop ourselves. So rather than seeing stress as a terrible bad thing, you see it as a thing, and it's something which you deal with. And some stresses are actually positive stresses. I mean, you know, getting married and having a wedding. Well, I had one patient who phoned me up in a tiz because she was stressed out because she had gone to the hairdresser and the hairdresser hadn't done her hair exactly like she wanted it for the wedding, and she thought, oh, I'm relapsing with my bipolar disorder. Well, I said, I think it's completely normal what you're experiencing here. Let's decide how you are going to deal with it and who you're going to bring in to help you with that. And I went over and I cut her hair for her and I colored it, and it was amazing. No, you bring in the hairdresser who can actually do that, right? Part of the collaborative partnership. But also to understand that the body has to respond to stress. Again, a lot of people come and say, oh, I don't want to be anxious. Well, if you're not anxious, a little anxious, you can't perform at all. And, you know, if you have no anxiety, you're in a coma. And you need to be able to deal with stressful situations and early warning signs, and you also should monitor. So this feeds into Health Plan 2 because it's saying, what do you need to do when things are not quite right? So the equivalent of the driving on the road is when you're doing a trip in the middle of the night and it's raining and there's roadworks and you're driving the equivalent of the Black Spur. You know, you've got to jolly be careful. You can't just go and drive how you would normally drive on a nice sunny day. And yes, you're going to be stressed and you're going to be more vigilant because you need to be. And then you get through that and then you can restitute and relax. So you can go back to this and make the point about the stressors and your strategies. Here we go. The stressor, this context of the driving on the road. And we do like to go through this with patients. I find people actually do like to know what's going on in their brain. And, you know, sometimes some people, you know, have read about the amygdala and what the amygdala does and all of those things. If you want to use all of that, you can do that. And, you know, pointing out that what they are experiencing in terms of the physical changes are normal and necessary. And then you go through what you would think, you know, is a stressor for you, like, you know, exams, or this is financial issues. You can put down the stressful situations, the early warning signs of you not coping. That is very important as well, because if things are starting to go too much and you're starting to skid around on the road, and you're going to fly off the Black Spur, well, that's not going to be good. So, you know, if that happens, you don't panic and shove the brakes on. You slow down slowly and you maybe even pull over and have a little break from the driving or whatever, and bring in other people to help you. So with the financial stuff, well, we have people who can help you with that stuff. And this is the monitoring process from which really just nests it into your everyday, which is again a very important part of OHP. It's not just what you do in the sessions, but between sessions, right? So monitoring of your daily stress, and you get them to write down a few things. I mean, it doesn't have to be exhaustive, but you're really wanting to get this sense of the context. What happened? Where was I? And what did I do? And how did I feel? What were my stress signs? How important was it? And then you ask people to reflect on the cumulative effect of all of this. Comes back to this model and my strategies. And you don't tend to tell people what their strategies should be. And some of them are immediate strategies to deal with stress. By the way, we're just working on a whole lot of materials for patients to help with things like sleep, things like how to breathe. I mean, it sounds ridiculous, but people like putting exercise in place, all of these sorts of things. So you'll have all of those backup materials for your patients as well. And you get them to put those things down, positive and negative stressors, as I said, and then how you would go about trying to prepare. Okay. So this is then pushing the health plan to maximize the effective strategies by creating collaborative strategies, things to do when noticing early warning signs, and support while maintaining self-agency. So it's not saying you have to call in someone because you're not coping and you can't manage. It's not that message. It's saying you can pull in some other people and they will help you, just like you would help them in a similar circumstance. Okay, I'm going to stop there.